So my topic is quite debated because the cardiometabolic impact of androgens in women is really an area that's not been thoroughly studied. So let me drive you through the concepts that we have more than the evidence that we have, and with the aim of launching messages that may be picked up in the future for research, which is certainly highly needed. So whatever we know for the androgen counterpart is in part derived as a parallelism from what we know from the estrogen point of view. So menopause and cardiovascular function, we have lots of information from the estrogen part. So when you have estrogen decline, you have effect on metabolism, you have effects on the vessels, and there's a clear relationship with the worsening structure of the arteries and the incidence of events, both in terms of arterial events, in part venous events, and brain events. And androgens is a big question mark. Indeed, it makes sense to think that given that the age after 50 is associated with differential levels of estrogens and androgens, there may be also relationships with the declining levels of androgens, as Rossella has said before, do not decline steeply with menopause, but do tend to go down progressively between the ages of 40 and 65, since this is the age when the likelihood of developing a cardiac attack is increasing in female. On the other side, and this was also hinted to by Rossella before, so it's easier for me to readdress this, the overall amounts of androgens that a woman has are largely exceeding the amounts of estrogens. And this is very important, not just because of the direct effect that these hormones may have on tissues, but also because, as you have heard, both from a metabolic point of view and also inside the cells, these are also sources of estrogens. So whatever we know about the relationship between estrogens and cardiovascular disease may also be influenced by the levels of androgens in that particular woman, and that has never been controlled in clinical trials. So currently, there's many ways to look at the problem, and during my talk, I will try to address the two extremes. So the situation that was in part addressed by Professor Shangyang Ruan earlier. So what happens if a woman has too many androgens, and of course, here we have a model that we do use to try and derive information, which is the model of polycystic ovary syndrome, which is not really a correct model to determine the level of high androgens in absolute terms, because as you've heard before, you have a lot of characteristics that impact metabolism in PCOS women that may go beyond the simple effect of androgens. But anyways, in PCOS, you have metabolic derangements, and you have also derangements of the vascular system that are well recognized. And you've heard that before as well, and here you see the numbers in this large Danish survey. PCOS women do have a clearly higher risk of developing conditions that imply higher risk of cardiovascular events, diabetes, particularly obesity, certainly hypertension as well. So in odds ratios that go well beyond the odds ratio of 2, but they go beyond 3 or 4 as well. So it's a clear risk factor. This is an interesting cohort where you can see the association in hyperandrogenic PCOS women as compared to non-hyperandrogenic women of carotid intima media thickness, which is one of the cleanest morphological parameters that we know is associated, for instance, with estrogen decline and with increased risk of a cardiac event, because it marks the atherogenic formation at the levels of an important artery. So here what you see is that independently from the weight, either these women are lean or they're overweight or they're obese, being hyperandrogenic adds to the levels of carotid intima media thickness, which is actually very interesting and important because it's one of the few studies where these two factors have been independently correlated. But this is a symposium from the International Menopause Society, so we really like to understand better in this aging time what is the relevance of having too many or too few androgens. And here we do really have little information. But some data we do have, even if with designs that are not as strong as we would like. This is a cross-sectional studies on about 50 postmenopausal women. And in this study, there was a correlation between levels of testosterone, and those that were in the higher part of the range tended to have a pro-heterogenic profile, which again marks the fact that at least a statistical association between the levels of androgens in the higher range and the biochemical markers of heterogenesis can be found in some small studies. But as I said before, the main problem, and Rossella clearly stated that as well, in women around the age of 50, is that the androgens levels are falling down because they fall down progressively across life. And this has implications for sexual function, for bone and muscle mass, and potentially for cardiovascular risk, although this is really the field where we miss information. Again, these are smaller studies that do tend to show that if you are in the lower range of testosterone levels, and Rossella clearly said before how difficult it is to differentiate small differences in the lower range of testosterone, which is the technical issue that impedes us to go more into the differentiation of patients. But anyways, if you're lower, you tend to have less efficient vascular dilatation in terms of flow-mediated dilatation, which is a strong correlate of endothelial function and of cardiovascular risk. So I think this is really the most informative study, which really states a concept that is interesting for future research. This is a big cohort. Elizabeth Barrett-Corner is the senior author, as you can see. The interesting part is that it states that either women that are in the lower range, but also those that are in the higher range, tend to do worse in terms of cardiovascular events. And this has introduced the concept that there's some sort of ideal amounts of androgens throughout the aging process. So you see this is a cohort of women between 50 and 90, which may be good for cardiovascular health. And this is actually very similar to what has been studied, for instance, with DHEA levels in males, where we do know that there is an optimal range that is associated with lower amounts of cardiovascular disease. So there's going back to the initial slides, the two main areas that have been tackled with estrogens in trying and assess the effects on cardiovascular disease is, do they work on the vessels? So are they maintaining or influencing the function of the vessels, or are they mainly acting on metabolic parameters of cardiovascular disease because they influence, for instance, fat tissue, liver, synthesis of proteins that do influence metabolism. So to this extent, I'll use data from our lab just to pinpoint that this is actually true also for androgens. These are endothelial cells, and here we are looking at the effects on cell viability, so survival of cells exposed to testosterone or to DHEA that can be converted into these cells, both into testosterone and in estradiol. And you do see that these hormones do promote cell viability. So they're not bad. Actually, they're good for endothelial cells, at least when they are isolated in culture. And if you look at the production of proteins that are typically associated with functional endothelial cells, UPA, PI1, modulators of angiogenesis and and coagulation at the endothelial levels, they also do modulate these genes effectively. If you look at the cells and their ability to modulate their shape, which is associated also to vascular remodeling, again, testosterone particularly, but also DHEA, increases the ability of these cells to activate these types of movements. So these are just spot information. There may be several others that do show that the concept that androgens are effective at the vascular level is as true as it is true that estrogens are effective at the vascular levels, where we do have many more information. And from the metabolic standpoint, here we have several studies in animals, very extensive studies in animals done particularly by the group of Frank Mauvais-Jarvier, a friend of mine. He works now in the United States, and he's an expert on the relationship between steroid hormones and diabetes, and he's done many, many studies, particularly in mice. So what he's been able throughout a career to show is that there's a tight relationship between both estrogens and androgens and insulin effect in these animals. And as you can see, both during development, so during in the early age of these animals, there's an effect of androgens on adiposity and insulin resistance, and when the animals become adult, there's more of an effect on obesity. So both a central and a peripheral effect. We do have effects on estrogens as well. So we do know that, for instance, at the level of peripheral fat and visceral fat particularly, the changing levels of estrogens are associated with changes in the biometabolic action of visceral fat, which do turn at the time of the menopausal transition into these sort of effects. Things that do result in less insulin sensitivity or pro-inflammatory actions that are important in the vessels. And from Frank studies, you do see that there is a very similar effects with androgens as well. So again, we're kind of looking at a mirror that shows that all the steroid hormones do tend to overlap in terms of metabolic effects. We just need to understand how they interfere with each other, because they work through different receptors. This is a study from our group, from Andrea Giannini and Professor Genazzani, who have tackled the central effect of androgens. This is DHEA administration, this is in women, on the production of beta-endorphin as under the challenge of an GTT challenge. So you're actually giving a metabolic stimulus, and you do see that if you have DHEA supplementation, the response in beta-endorphin secretion becomes better in women. So to this extent, I think this is very interesting, because it's one of the few studies that shows that the androgen supplementation can alter the central response to metabolic stimuli in women around the time of menopause. And this is again pictures which are, I think, very informative that come from our lab. These are fat cells cultured, a lot of white spots. The white spots are lipid droplets, and you can see that here, when you see the T sign, this is testosterone. So early on, day 4, day 8, day 12, day 15. So throughout the days, testosterone stimulates the accumulation of lipid droplets that you can see more clearly here, which is a sign of differentiation of these cells. And this is the count of the droplets. So I'm moving towards conclusion to say that whatever we know so far is very limited. We do have a clear appreciation that androgens are important. But we do understand that they're important either if they're very low or either if they're very high. And we don't understand why these two very differential concentrations of the same hormone turn into similar effects on, for instance, vascular function. So we really need to devote more study and to differentiate more clearly the actions of these androgens as compared to the effects of declining estrogens. Also because we need to understand the role of supplementation, which will be the topic of the next presentation. So I will not enter into that. Thank you so much.